and a very sunny Belfast and Dublin today. So it's a pleasure to welcome everyone attending our plenary event, supported by the Health Research Board of Ireland and University College Dublin. So today we're covering pillars 7 and 9 of IFIC's 9 pillars of integrated care, namely digital solutions and transparency of progress, results and impact. Next slide. My name is Sloan Harper. I'm chair of IFIC Ireland, and I will be facilitating this session along with my co-chair, Professor Áine Carroll. So Áine is Professor of Healthcare Integration and Improvement at University College Dublin. She's also a consultant in rehabilitation medicine and is a director of IFIC Ireland, as well as vice chair and secretary of IFIC. So Áine's a busy lady, but she's taken some time out to help with our facilitation today. And we have a brilliant keynote speaker and a panel for a really excellent discussion I'm sure we'll have this morning. But first, we're going to start with a short video, and it's covering the development of the IFIC Ireland Hub to date.
My friends and colleagues, it is a very great pleasure to welcome you finally to Dublin. And I can't quite believe that it's finally arrived. As Nick was saying, this is something that we've been talking about and planning for 2 years, at least 2 years. And when you think that there are 1,200 delegates here from 54 countries with another 400 colleagues on live streaming, I think it is a real sense of community and coming together in a movement for change. So when I think about what, from a HSE perspective and from the people in Ireland who've been working together towards integrated care, what did we want to get out of co-hosting a conference here? Well, we wanted to connect with you, we wanted to make new friends and to establish networks. We also wanted to celebrate the work that's already underway. There are people already working to make the changes that we want to see. We want to learn, we want to improve the work that we're doing, and most of all, we want to collaborate. We want to be part of a global movement for change.
Ireland's integrated care journey to date. We really need to find ways of getting across that actually integrated care is a journey. It is a long journey, it's a difficult journey, but it's a very worthy journey, and it is a journey that everybody in this room is on. Is partnership working? Us really coming together as partners in not just the design and the delivery, but the thinking about how we might even think about the things that we want to do.
Their interests are aligned with yours. So how can we get around that toxic problem and get all of our interests aligned? Well, in Northern Ireland, we developed back in 2013 integrated care partnerships. Victor Hugo, who once said, greater than the march of mighty armies is an idea whose time has come.
the webinar series is a very important part of bringing people together and sharing our knowledge and experience on integrated care in Ireland, but also internationally. All share, all learn is the motto, if you like, for the community of practice that is integrated care. So the webinar series consists of international and Irish speakers focusing on disseminating knowledge of best practice in integrated care for an Irish context.
Okay, IFIC Ireland is one of 4 hubs. We have colleagues in Scotland, Australia and Canada, and it's always a pleasure to work closely with them. If you're a region that's thinking of establishing a hub, I'll just give you some brief details on our governance and structure. It can be a dry subject, but it's absolutely essential. And we couldn't do what we do were it not for the support from IFIC and also from University College Dublin in terms of governance. I work closely on the executive team with Áine and also with Fiona Lyne, without whose input. Fiona is Director of Communications at IFIC, and we wouldn't be having this or previous conferences were it not for her excellent work. Our operations team keeps us on track and makes sure we don't sit on our hands for too long. And we are also developing our research function. The steering group keeps us on track in terms of what's important to patients. And Jackie Brown is essential to this. She's our patient and third sector representative. And our knowledge partners have been an excellent support in developing an approach to sharing and promoting integrated care across the island of Ireland. Next slide. So in terms of our plans for 2021, the video has mentioned our webinar series and mobilizing knowledge and also the adoption and spread of integrated care is our mission. Value Care has been a tremendous European project. Áine is heavily involved in that with our colleagues in Cork and Kerry in the palliative care study, and that's making great progress. Our leadership development certificate is underway at the moment, and we have a whole series of communications and newsletters, and we'll give you contact details at the end of the plenary session. Next slide. Okay, thank you, and I'll hand over to Áine.
Thank you very much, Sloan, and it is a very great pleasure to be with you today with what I can only say is a veritable feast of expertise that is before you this morning, or wherever you are in the world, whether it's morning, evening or nighttime. And it is my very great pleasure to introduce you to our keynote speaker, Dr. Jeffrey Braithwaite. And I've had the pleasure of hearing and meeting Jeffrey on a number of occasions. And the things that Jeffrey's interested in are things that those of us who are interested in integrated care are very interested in. So Jeffrey is the founding director of the Australian Institute of Health Innovation, director for the Centre of Healthcare Resilience and Implementation Science, a professor in the Faculty of Medicine in Health and Human Sciences, Macquarie University in Sydney, and also president-elect of the International Society for Quality in Healthcare, with whom we work quite closely in IFIC. And Jeffrey has published widely, is just not a wide enough term to use, but has published in areas to do with paradox, complexity, improvement, safety, implementation, all the things that those of us who are passionate about integrated care are also similarly interested in. And Jeffrey is going to share with us today the 3 numbers that we need to know in healthcare. You are very welcome, Jeffrey.
Thank you indeed, Áine. It's a complete pleasure to be working with IFIC and Irish colleagues, and of course, colleagues across the world, to whom I wish good morning, good afternoon, and good evening, wherever you might be. So thanks very much to the sponsors and you, Áine and Sloan, for your leadership and a great panel. In some respects, I'm just the warm-up guy for the feast that you mentioned, Áine, which is the panel discussion. And I hope to provoke some of that and then contribute to it. Really, this is about a couple of things that are very hard to crack. This is, you mentioned journey, both Sloan and Áine. This is a journey of improvement that we are on. We who are on the journey that you mentioned. It's a journey of integration. It's also a journey of sustainability. How do we create health systems that are built to last, that are future-proofed? And I'd like to riff on those themes, if I may, during this talk. So let me move my slides and address this idea of 60-30-10, which I've published a paper about recently. I'd like to take that in the context of what we're discussing with IFIC's interests. So firstly, I guess I'm from the Australian Institute of Health Innovation. That's a big research group, a couple of hundred people in Sydney, Australia, but with a footprint of colleagues we work with around the world, all interested in how do we improve health systems. So our motto, just like you've got some leading words that you work with in IFIC, Áine and Sloan and colleagues, ours are heal, learn, and discover. And I spend most of my time in this area of discovery and learning. My institute, a couple of hundred people in Sydney, but working with lots of people around the world on health systems improvement, essentially, has several university centres headed up by Enrica Coira, Joanna Westbrook, and myself, plus a whole lot of other funded centres, which I'm including in this slide to give you an idea of the flavour of the kind of research grants that we get. Not to advertise that, but so that if your work maps to any of those ideas, feel free to get in touch with me and we can have a chat and we can do some research together, or we can explore and go on the journey that Áine and Sloan tell us we're on together. So just by way of introduction, those are the kind of things that I'm researching and my colleagues are researching. So first things first, what will you do to change this and improve the system if I say the system's like this? Doesn't matter if you can't see the details. What will you do to improve the system if I describe the system as so many health systems do by showing an organization chart? But what if I say to you, you have to change and improve the system if I describe it this way, like the diagram on the right? And what I want to put to you is we do a lot in healthcare of work as imagined. We imagine how the system is when it's working really well. Everyone knows the hierarchy. Everyone knows their place as a box on the chart. But actually, what we sometimes fail to adequately take into account is the way work is actually done in the real world. And I'm going to put to you a strong claim that we need to understand and work in both worlds. But what I see a lot of in many health systems is people working in the organizational boxes on the chart. And what that sort of logic takes you to is, hey, I better restructure the system. If you do that, though, you may not be affecting change the way work is actually done. And your improvement efforts may not affect the people who are actually doing all that stuff in the squirrely diagram, which is actually how clinical work gets done. Hold on to that because I'm going to return to it. So let's move back from that. I'm going to come back to that. Let's move back from that and talk a little bit about the international context. It will not have escaped you that many people are working on integrated care. Many people are working on improvement. Many people are working on how do we create a sustainable health system. So here's 3 big reports that were produced in 2018 from the American Academies of Sciences and the WHO and the OECD and the World Bank and the Lancet Global Commission, trying to work out how do we at the international and national level improve care, very dear to the hearts of IFIC and all of the people who are around these concerns here that we're interested in my talk. And what this essentially was in 2018 was a global call to arms, a call to say we can't do change and improvement the way we always have. We have to do things differently. And one of the claims that was made was we have to be on a journey of improvement. And another claim was made that we have to factor in the system's characteristics, the extended system and the way it behaves in order to make change feasible and possible. So my question for all of us is, if 2018 was the year of analysis and reports from all the big international players, can we make the 2020s the decade of action, real, genuine action of the kind that IFIC has been talking about for a number of years? That's the challenge, I think, for me, and I think for us in a nutshell. Okay, we're already through 2 parts of my talk. Let me go to part 3. What does that mean then if you're talking about whole health systems and you're saying, how do I reform that system, whichever system it is that you're currently in? Well, I've been series editor of a series of books that are about health reform in international context. The first book to the left there was a book on involving 30 countries, looking at how do they do quality and safety. These are with a lot of colleagues who are writing chapters on their countries, and it summarizes a whole lot of things that people are working on across the world. The second book, I involved 60 countries, and I asked, what is it about your health system that you can offer where you've made some improvements to the rest of the world, where you can be a stimulus for change elsewhere? The third book asked this deceptively simple question. What do you think health systems are going to look like over the next 10 years? What do you think are the key changes that are going to occur across the decade of the 2020s? So just taking that third book, because I haven't got enough hours in the day to talk about all the books I've been working with colleagues to try and summarize all this international evidence, taking the third book, it covered all these countries that are colored. I couldn't get to some countries in a couple of continents, but we got to actually 152 countries as collaborators to this book. So these, although it's a 500-page door stopper of a book, I'm going to summarize it for you, and I can do so quite quickly. So all this wisdom from all these countries summarized. So what it says essentially is there are 5 major themes that are running through health systems across the decade of the 2020s. Trying to create sustainable healthcare, looking at high technology things, especially in the wealthier countries like genomics, exploiting new emerging technologies, including drugs and all sorts of other things that's coming down the pipeline to us, looking at global demographics which are changing. And I don't mean to be insulting to this audience, but I have noticed, even though we've just met each other, that you're aging as one contribution you have to changing demographics. So all countries, even the ones that are young and relatively in the new world, are aging quite rapidly. And then fifthly, new models of care. And we've seen that, of course, during COVID, have we not? Where telehealth suddenly blossomed, whereas some of us were trying to beat that drum for years, and then suddenly it became feasible in many health systems. So those are the 5 major themes. If you like, those are what is happening across the decade of the 2020s, and we probably couldn't stop those occurring. But in addition, in that 500-page book, there were 9 major themes that people were working on. And these are the 9. I won't talk about each one of them. Áine and Sloan, I asked them if I could have 20 hours instead of 20 minutes, and they said, no, Jeffrey, you can't. So I haven't got that much time. These are the 9 themes, and you can see them for yourself. These are the things that people are working on to try and improve. And so you can see in your own health system how people are working to a greater or lesser extent successfully on these 9 major things. These 9 major things that people are working on to try and improve their system. And you'll notice, Áine and Sloan, I didn't manipulate this. This is straight out of the book. Integrated care was the first thing on the list. You'd almost think we had tic-tac beforehand and worked this out as a script. So the other thing I'd like to point out to you, and again, I won't lecture for a whole chunk of time. It's much better that I stimulate some discussion and thoughts and then get to the panel discussion. The mirror from the Commonwealth Fund, the mirror report in 2017, also quite a recent series of research findings about health systems and how they might be improved. And it shows, this particular report was really to compare the US with a number of other health systems, and it doesn't perform favorably when you look at systems that are much more universal coverage and don't spend as much on healthcare as the US system does. And this was US authors saying this rather than me trying to criticize our US colleagues. But it showed that performance differs across countries regardless of how much financial input is at the front end. And the US, which spends most, is on many respects the worst performing system. One question I've got, by the way, to my Irish colleagues is, the Irish health system isn't in here. So I'm wondering out loud with you, are you there as a better performer, or there as a medium level performer, or are you not as good a performer internationally? I don't have the data. I'm not criticizing the Irish health system either. I'm just saying I don't know, because those are countries that were in this study and Ireland isn't. So here are the top 3 performers in a grid. And if you have a bit of difficulty reading that, well, the slides are available for you to have later to have a look at in more detail, or you can go to the mirror report. And the 3 top performing ones are first the UK NHS, the NHS in England. This is pre-COVID, and I'm not sure how it would be seen to be performing now. I know there's a lot of international discussion about that. Secondly, Australia, and thirdly, the Netherlands. But one of the most interesting things about that is that those 3 countries are completely different in the way they structure their healthcare system. So, sorry, I moved on too fast then. Let me just go back there. For example, the UK's national health systems are taxpayer funded with a very small private sector. Australia's is a more blended system with a taxpayer funded system for about 2/3 of it, and 1/3 is privately funded. Netherlands has competing private health insurers. So those are 3 top performing countries according to this report, and they are structured and financed differently. So it may be that how you structure and finance your health system isn't as important as the workforce and the culture and how integrated it's becoming, and those other themes that I was talking about earlier that people are working on. I'll just leave you with that. I want to put that proposition to you. So whatever your health system, however it's shaped, however it's funded, however it's structured, my proposition, and I've written a paper on this recently, and it's the paper that I think Áine and Sloan caught hold of and said, we better have Jeffrey have a talk to us, is that we need some numbers to manage the performance of any health system, whether we're becoming more integrated, or we're working on how we improve care, or we're working on quality and safety, whatever it is that is our major work that we're doing to try and improve that health system, or all 9, which I put on the slides earlier. So we need some numbers. And I've thought about this an awful lot. I work with health systems that have hundreds of KPIs, key performance indicators. I work with systems that are awash with indicators. And I wonder if we need all those. So I've been thinking, and I've published a paper on this so you can critique it if you wish, in BMC Medicine, called Just 3 Numbers, essentially. And I'm wondering whether there are three central numbers, whatever we're doing to try and improve health systems. And those numbers I've put into a little aphorism, a little logo of 60, 30, 10. So this is from quite a number of studies that I've synthesized into this one paper. 60% is the amount of care in most wealthy health systems, whenever we've measured it, that's in line with level 1 evidence or consensus-based guidelines. That's evidence-based care. 30% is the estimate for the amount of waste that is in health systems, where we could spend the money that we waste more wisely. Now, waste is a hard word. What I mean by that is these are test results that never get seen, or care that shouldn't be delivered, through to administrative costs and bureaucracy that you have to navigate through, and there's a burden and cost in the health system because of that, through to all sorts of different ways that we found to not provide value-based care. And 10% is that magic number we hear about at almost every conference. This is the amount of harm, or I know clinicians sometimes call it complications, but it's harm or an adverse event that befalls a patient. They come in to our systems for the care that they need, the treatment they need, and they end up with a fall or an infection or the wrong dose or whatever might befall. So 60, 30, 10 is a snapshot of most health systems. And of course, if you boil it down to that, then you just have three numbers to work on. If you can get the 60 up and deliver care that's more evidence-based, more reliably, if you can get the waste down and the harm down, you're going to have more resources in the health system. You're going to have better care. You're going to provide better care to patients. So I wonder if we need, I'm just going to leave this hanging for you. I wonder if we need all those indicators when I think there are three central ones that if we beat those numbers, we'd have a better health system instantly, automatically. So that's the tenor of that talk, that paper. So you can play with this as you wish, or the panel may want to refer to this a bit later. I'm contending in that paper that if you make progress on these three numbers, then you're on track to creating a learning health system, one that learns about beating and creating more evidence-based care, less harm, less waste. That can't be bad for patients and providers. But there's other numbers to factor in, isn't there? And you can go to conferences and hear those numbers. Sorry, I may have missed a slide there. It takes 17 years for only about 14% of everything that's done, that's research, to get into practice. Or there's 75 trials and 11 systematic reviews published every day. And my joke is, I don't know why you're listening to me, you're behind in your reading today. And there's 4.9 billion internet users today. And there's billions of websites, and there's billions of emails being sent and received every day. These are the numbers. By the way, if you want to see those numbers live, go to Internet Statistics Live. You'll be mesmerized at this website if you haven't been there. So that's the volume of stuff, numbers, data that's being produced, not by health systems, by some people in health systems, but by the world. Then if you also factor in all the data that's being produced by healthcare, health and social care, however you set the boundaries, and I think the panel's going to discuss how do we set the boundaries on this, then how do you deal with all this digital information that comes to you? How do you make sense of it? How do you integrate care, as Sloan and Áine want us to do, in our health system when we've got this level of complexity to deal with? So I've used the complexity word. Áine and I love this sort of whole thing, and we spend time talking to each other every time we manage to get together in the same place at the same time on the same part of the planet. We'll need some understanding of complexity science to deal with that level of complexity that I'm suggesting, because we can't just leave it hanging and say, so we've got a tough job to improve healthcare. So be careful. Most of us spend quite a lot of time thinking of linear solutions to these kind of problems, and that's not really going to work for us. That's the organization chart I showed you, where it's an organization chart with boxes in it, and we spend our time restructuring it, thinking of linear solutions. So here's a paper we wrote a couple of years ago. It's on open access. It's a white paper we wrote in my research institute that's been cited a couple of hundred times, and it's only a couple of years old. And this says, what do we do about this idea of complexity in healthcare? How do we navigate through all the complexity to achieve what we'd like to achieve, which is a more integrated, higher quality, a safer system for patients? So here's the properties of complexity. I'm not going to deal with these. This is just my way of summarizing in one slide all the stuff in this 80-page white paper. So you probably don't have to read it. I've given you the slide. But complexity is described as all the melange of people and artifacts and interactions and the production of care that's represented by that swirly diagram I showed you at the start, rather than the organizational structure with its nice, neat boxes. And that's what we have to try and work on and improve if we're going to have a higher quality, safer, more integrated system. These are the properties of complexity. So we do a lot of research in this area. I'm just going to snapshot a couple for you. One is we do work looking at how people network together. Who's who in the zoo? Who are key to our efforts to make improvement, to integrate the system? So you know these diagrams, you've seen them before. The circles are people, and the lines between them are the connections, the relationships between the people. So we started in 2013 on this journey with a translational cancer research network in Eastern Sydney. You know where that is? That's where Bondi Beach is. And that's the hospitals in the eastern part of Sydney. By the way, colleagues, it's winter in Sydney, or winter's arriving soon, and it plummeted to 22 degrees centigrade today, which is why I'm at home wearing a jacket. So take pity on me, please, especially you Irish. So we started in the start of a decade ago, looking at how connected were these people. These people are researchers and oncology staff, doctors, nurses, allied health professionals, collaborating in a translation cancer research network. So we got this funded and we started work trying to get more evidence into oncology practice. This was the network diagram then. This is the way it was a couple of years later. This is the way it was a couple of years after that. And this is the way it was in 2017. And we've just repeated this research in 2021. And I can't show it to you because I would have to kill you first. It's to be released, but you can follow the pattern and assume that 2021 follows the pattern that you're seeing there before you. So what we've managed to induce here in this complex network of researchers and clinicians working together is really a whole lot of relationships to try and work concertedly, researchers and clinicians and policymakers, to improve care for patients. So this is the way we do this research when we're looking at the complex adaptive system. So, okay, that's a bit on complexity. So we're going to need some tools. If we're on a journey to 60-30-10 and improving those numbers, let's look at change in a complex system. Let's look a bit more at that. And then Sloan and Áine, I'm going to finish. That was just my hint to them that I'm not going to go on forever. So one is to put what we do on an improvement gradient. Here's a model we designed, and this is evidence-based out of research we did, but there's lots of these around. You can look at these through the literature, or you can look at all 27 million papers in PubMed, and you'll find lots of models like this. This is ours. But what I think is important is, if we're going to evaluate our progress along the way, it's not sufficient that we have IFIC and good integration. We have to measure as we go along. I'm a researcher. I'm a quantitative guy. I want to see the evaluation of what we're doing across time, so we can create feedback loops in the complex system to improve things. That's my plea to anyone, policymaker, manager, clinician, patient group, who are trying to induce change in a health system. Yes, be on an improvement gradient, but measure as you go along. Then we'll know where we've come from. Another example is people, this is another study we did, people in a system don't really fully comprehend its complexity. they tend to use that bit of the brain that simplifies. So here we were working with some providers who do Lynch syndrome. And we said to them, what do you do? And they said, well, we do this. We sort of screen and then we refer patients. If they're, we screen, and if they're high risk, we refer. And we said, tell us more about what you do. And did. And they said to us, we just told you. We screen, and if they're high risk, we refer. And then we sent a couple of sociologically trained anthropology type people into their environment. And this is the map of how they delivered their care, delivering to Lynch syndrome patients. Doesn't matter if you don't know what Lynch syndrome is, by the way. So the very people who were doing the care couldn't describe all its complexity. So this is a plea for really standing outside of your own clinical practice, standing outside of your policy environment, standing outside of whatever you do in the system, and having a look at it as it actually is, rather than how you imagine it to be. This is the difference between work as imagined and work as done. So 7, you're going to need some solutions. You're going to need some implementation science, aren't you? If you followed the logic so far, I've set up a pretty decent problem. I've said we've got some tools for researching this that aren't just linear, like if you issue a policy, you're going to get a change in practice, because that's not going to work on its own. Any really seasoned policymaker knows that in their heart. Just issuing the next policy or just issuing the next guideline to a bunch of clinicians and walking away saying, hey, they're going to carry out care according to the guideline. Some of them might, some of the time, but not all of them, all of the time. So we're going to need some tools. So I'm going to finish on this. There's lots of implementation science tools. So here's some that we work with. One I've already said to you. Have an improvement gradient and measure along the way. Another one is really prepare for the change. Think about the change that you're trying to induce in the system. Do some really seasoned, organized improvement, rather than how I see it sometimes being done, by the seat of our pants. So have a model, in other words. Doesn't matter if you don't use mine. There's lots around. The other thing is create a virtual cycle of going to scale. In every health system, there are pockets of things that are done well and mediocre things done sometimes just along the corridor in the same organization. And the mediocre places, or the not very well organized, or the not doing as well places, somehow don't learn from the other places. In every health system, there's some really stellar hospitals. There's really some stellar general practices. And we find difficulty in learning from those. So we have to figure out, using models like this, how to go to scale. And in a way, that's what IFIC really is. It's a massive concern for trying to go to scale with integration. And that's why I love working with you. Another one is, every hospital I've ever worked with has said, every teaching hospital I've ever worked with has said, Jeffrey, we're a center of excellence. Well, hang on. You can't all be a center of excellence. And I've noticed that you sometimes don't produce really, really excellent care all the time. And you've got some departments that, to be honest, I wouldn't go to for care. So it can't be the case that every teaching hospital is a high-performing hospital. So we looked in the literature a couple of years ago. We summarized all the factors in a high-performing hospital. And I leave it for you. It's been cited a lot, this, and it's used by a lot of teaching hospitals to benchmark themselves to see if they really are excellent. They still put on their website that they're fantastic, by the way. But internally, I like to see them thinking, am I really as excellent as I'm claiming to the outside world? Can I do better? So here I'm leaving you with this paper on what a high-performing hospital is from 34 studies that we looked at, looking at how well were hospitals performing. And this little graphic shows you the key things in a high-performing hospital. So next time, one of the teaching hospitals in your health system says, we are a center of excellence, you can say, hang on, I'm just going to benchmark you against Taylor et al., Jeffrey Braithwaite's colleague, and how well you're actually performing. So enough from me. Here's some lessons to finish with. And these are the summary of, I've been researching for a long time. You can't believe how many years I've been researching to get to this ripe old age of 35. You cannot believe how much research I've crammed in to that 35 years that I'm been doing research. Those 35 years of age, been doing research for what, 10 years, a whole decade. So don't ever think that change is easy. I know you don't, but it's nice to be reminded. Progress will always be hard won and hard work. Linear thinking, the organization chart, let's just restructure the boxes on the chart, or let's just issue some more policy, or let's just give clinicians another guideline, will only get you so far. You've got to work with the natural characteristics, as we do in our research, of the complex adaptive system. And by the way, look out for unintended consequences. Whatever you do, you will have some consequences that you can't predict because it's a complex system. It must throw up things that you can't predict. Don't do it alone. Whatever you're doing, whether you're the CEO or the chief of the health system or whatever, it's not all down to you. It's a system of systems that you're working with, so you must harness others. Always to do the kind of change we're thinking about too, this integration or sustainability or improvement or 60-30-10, you're going to need some institutional leverage. You're going to need some buy-in from the people up there. I haven't talked about this time in this talk, but another bunch of work I'm doing is on looking when things go right, rather than the preoccupation we have with things going wrong. And I'll have that, if you ever invite me back, Áine and Sloan, after this talk, another time. I'll talk about our work in resilient healthcare and things going right, not things going wrong, which is also a very important piece of the puzzle, I think, for reforming health systems and having better care for patients. And finally, and I think I've just about met my objective, I hope so, I may have gone a couple of minutes over, you'll have to forgive me. Finally, some questions for the audience and maybe the panel to ponder, although I think Áine's got some jaw-dropping better questions than this. Given the complexity of data and systems that I've described here, the sort of digital preponderance of information that we're faced with, what can we hope to achieve as we integrate care with all that data that we have at our disposal? Secondly, is the 60-30-10 paradigm that I'm arguing could be quite useful, is it as useful as I think, or is it unduly simple? Maybe you need hundreds of indicators in your health system. I'm happy to be convinced. And then thirdly, how much should we look outside of health and social care? What I've noticed recently is how much influence outside of the care system, what we normally think of as health and social care, how much of the health behavior is influenced by things outside of what we normally think is our control. Amazon, Google, Facebook, social media. So these are considerable influences which are impacting vaccine hesitancy, adherence to screening, compliance with diet and nutrition, maintenance of exercise regimes, this whole idea of social media and the big companies that affect behavior on the ground in our societies are having a profound effect, and we probably don't think about them as much. And they've got data that you can't believe on our populations, and they're influencing those behaviors. So do we need to factor that data into our digital thinking as we try and create more integrated health systems? That's all from me. A couple of things. There's a wave from some people basking in the sunshine in Sydney, Australia. A few of the people in my institute. Here's an acknowledgement of all the teams that I work with here in Sydney who are instrumental in creating the research that I do, that I lead. And here's some recently published books to get your teeth into. I believe some of them cure all known forms of insomnia. So you must have one on your bedside table. And then finally, here's some books I'm working on. So stay tuned. I'll keep writing and researching if you keep reading occasionally some of my stuff. And this is how to get hold of me if you want to. Thank you very much. I really appreciate the invitation. I hope that's been useful. Back over to you, Áine.
Thank you very much, Jeffrey. And as always, I'm sure I speak for everybody in saying that that was a really interesting, thought-provoking talk. There are so many things that we could talk about. So you have posed some questions, and I'm going to save 2 of those for the panel discussion. But for the second question, is the 60-30-10 paradigm useful or unduly simple? And so personally, I think that anything that we can do to make it as easy as possible for frontline staff or at that meso or macro level to embrace complexity can only be a good thing. And there are so many different, you've given some nice tools within your talk. And I think that if you're planning to do a change or an improvement, find a way that suits you, that makes sense to your organization or your context. So I quite like it. But my question for you, or I should say, sorry, an appreciative inquiry, and not but, and I have particular bugbear around complexity. So, and you've done some lovely work in actually tracking publications over the last number of years. And I would urge everybody to read. Jeffrey and his colleagues write extremely well about very complex issues. And it really helped me to get to grips with my understanding of complexity theory and healthcare. However, in healthcare, we seem to use complexity in name only. We seem to find that when you actually look at the work that goes on within our different healthcare systems, it seems to be really a name only. The logic, if you like, or the complexity of complexity does not really seem to be embedded in the improvement work that we're doing. So how can we really embed complexity theory into the improvement work that we're doing, Jeffrey, given all the research that you've done over the last number of years?
So a couple of things I'd make a suggestion of. I think we need tools, and I haven't talked about the complexity tools. There wasn't enough time to talk about everything, but there are tools to try and help us. Look, can I just come back from your question's brilliant, okay? The architecture of the human brain is such that we tend to think if I do X, Y occurs. So this cause effect XY logic it's been very successful for Homo sapiens to get to where it is. It's a logic that helps us a lot. If I get a diagnosis, I will be able to treat the patient appropriately. If I plan to meet somebody at a meeting and we all know it's in our diary, we can all get there at the same time. If I make arrangements to get there, we'll all get there and we'll have a good meeting. Okay, so if then cause effect logic is very prevalent. Yeah. But if we take it to complex problems, we get ourselves into trouble. So if I just issue the next policy or the next guideline, I'll have fixed the problem. Or if I just integrate and get the GPs talking with the hospitals a bit better and get better discharge summaries, I'll have fixed the problem. Almost none of the problems we are working on are fixable by that linear cause. Because you know why? All the problems that we've solved are all the ones that are solvable by cause and effect logic. So the ones, you know my definition of an organization, a healthcare organization? It's what's left over when everything else simple has been fixed. That's why we have so many challenges in front of us, because it's all the stuff that we fixed by cause effect logic that's in the past. And now we're faced with all these truculent, difficult, hard to solve problems. So my answer to your question against that backdrop is we need tools. We need tools to help us with complexity thinking. One of them is systems dynamics. That is, we model the system that we want to effect change on. Another one that's doable is that social network stuff that we did. We didn't know when we started in 2012 that we would have this flourishing network by 2021. But we measured it across time and kept feeding back to people how well they were integrating with each other and working together. If we'd have just not done that and just assumed when we got to 2021 that we had a better system, we wouldn't know that we had a better system. But by taking the soundings along the way, we were feeding back to people how well they were doing. And that promoted more change. So I would use systems dynamics. I would use network analysis. I would take regular evaluations of the changes that the system is making or not making and feed it back to people. Then you're thinking in more systems and complexity language than in more linear ways.
Yes, and you're just while you're speaking there, you reminded me of what Donella Meadows said about, we need to move away from find and fix to learning to dance with complexity, which I think is a really nice way of thinking about it. Now, I'm conscious of time, Jeffrey, and I think that a number of the questions I had for you, we can actually put to the panel. So thank you very, very much for a very interesting keynote. We will certainly have you back to speak about some of the other areas that we've touched on today. But on behalf of IFIC Ireland and IFIC Central, thank you very much for a fantastic talk. And we'll now move on to the panel discussion, of which Jeffrey is part. And we have a digital extravaganza for you in the panel that we have lined up. And I'm very grateful to all my colleagues on the panel for participating today. And the biogs are all in the programme, so I'm not going to go through the biogs, but suffice to say, welcome Donna Henderson, Leo Lewis, Dan West, Carolyn Steele Gray, Martin Curley and Michelle. It is such a pleasure to have you all here today with your real profound knowledge of digital, and in particular digital in healthcare. So welcome to you all. And my first question, I think, has got to be, I can't ignore what has happened in Ireland with the ransomware attack. And apparently New Zealand, a health board in New Zealand, were also attacked by either the same or very similar ransomware. And I found myself thinking yesterday as I was thinking about questions for the panel, but I was thinking about when you think about the phase shift that there has been in clinicians and really the healthcare system embracing technology and digital solutions during COVID. What has the ransomware got the potential to do to undermine that trust in what we have managed to build over the last 12 months or 18 months? And if I could first pose that question to Dan and then Martin, and if the panel then wish to also contribute, I'd be delighted. So Dan, can I pose that first question to you, please?
Absolutely, Áine. And before I start on my response, I just want to say thank you to you and Sloan for the invitation to participate in IFIC. It's a great session, and thank you, Jeffrey, for your presentation. You mentioned the COVID pandemic there, Áine, in your question, and Jeffrey made the point that oddly we have a lot to thank the pandemic for. In that we've had greater integration of services in the theme of the conference today. Galvanizing around a common goal and driving rapid adoption of technology solutions. But in that context, what do these recent cyber attacks mean around trust and around adoption of those services going forward? So here in Northern Ireland, another part of the island of Ireland with a separate health system for those that aren't familiar with our structures, we've had recently, in the last 12 or so months, 3 RIOCs and a Conti, for those in the know about the tooling that's used in these cyber attacks. So the prevalence is increasing, and it's clear from these recent issues here in Ireland just alone that cyber criminals are becoming increasingly sophisticated and professionalized, and extortion is at the moment successful in a reasonable number of attacks. And it's consuming a vast amount of management attention. I liken all of this to shipping piracy in the Gulf of Aden in the late 1990s and 2000s, which seems quite peculiar, but I will get to why there is a similarity. So while there was an opportunity for criminals to make money, the risk continued for shippers and insurers. And as countermeasures were put in place, there was an escalation of techniques and tools by the pirates. And the reality is that we're in that mode of operations around cybersecurity at the moment. There is no panacea. There is no single fix, and it's down to the capabilities of the teams on either side of the divide to increase the sophistication of the attacks and increase the sophistication of the countermeasures. So to your question, Áine, clearly the impact of the sustained cyber attacks on services is disruptive, would be the first observation to make. But I think it's important for us to remember that this won't stop us digitizing services at the rate that we are able to, and hopefully at an accelerated rate in the future. What it will change is the nature of the work that we need to do in building, testing, and deploying those services so that we can weave cybersecurity measures in right from the outset at the design phase, and we can become increasingly sophisticated in our capabilities and responses. So there needs to be some investment. And I think that development of skills, working with researchers and academia to try and build our skill sets quicker than the cyber criminals is going to be incredibly important. And then how we bring those skills in and infuse them into our teams, recognizing that those capabilities have got a premium in the IT market at the moment, and public health systems around the world and in Western Europe don't always have the opportunity to offer the most attractive salaries. So there needs to be that building from the bottom up, that capability within our services, so that we can protect digitization from the outset.
Thank you very much, Dan. And Martin, can I ask comments from you, given that you're very close to the Irish situation?
Great, Áine, and thanks to you and Sloan for the invite, and great talk by Jeffrey. So delighted to be here. So in Ireland, just to step back, COVID has been a big bang disruptor for us. And we had very, very slow incremental change happening to our systems over the last decade, and arguably there's been zero to any progress. But because of COVID, we've actually leapt ahead, and we have implemented some solutions that typically might have taken 2 to 3 years to have adopted. We've gone from a concept to working solution in 5 weeks. For example, remote monitoring of COVID-19 patients. So we went from a concept and we co-designed the solution, and after 5 weeks it was being prescribed by many of the acute centres across the country. When I think about our vulnerability, I have a couple of thoughts. John Cage has a great saying. He says, "I'm not scared of the new ideas, I'm scared of the old ones." And when I think of what has happened, the new systems actually aren't the ones that are vulnerable. It's all of the old ones that actually have the vulnerabilities. And in Ireland, we have a particular problem. We have a huge landscape or a state of computers that are still working on Windows 7. So there's a massive refresh that is needed. But our strategy in Ireland really is to leapfrog. We've missed a decade of these complex electronic health record implementations, and where we want to go to is leaping ahead to a new home and community-based or hospital at home type service that's digital, it's mobile, and it's integrated. One of the implications of integrated care is integrated systems. And as we attempt to start up the systems in Ireland, we actually have 2,000 systems that are quite tightly integrated. Our CEO, Paul Reid, said, this is the equivalent of trying to start 30 years of technology in 2 or 3 days. So it's actually going to take us quite a while. But I think we can think of a new system architecture for the new integrated care and integrated systems we'll see, where these systems actually are loosely coupled rather than tightly coupled. One of the issues we have in starting up in Ireland is a lot of the systems are very tightly coupled or are synchronized. And I think the new architecture is where we have systems that are loosely coupled and work asynchronously rather than synchronously. I think we really need to apply the principles of defensive information warfare. Many years ago, I was head of corporate information security for Intel, and we got across the US, there was a series of distributed denial of service attacks. And people were, Charles Wang called it electronic Pearl Harbor, and Jeffrey mentioned the term call to arms, and what we now have is a call to arms collectively. I think if we looked at healthcare systems across the world, they are fragmented, they're fragile. Healthcare is at least a decade behind any other industry that I know. So IFIC, I think, actually has a very important sort of convening role and power in this situation. We're going to need a lot of cross-border collaboration, specifically around cybersecurity. So I wish I could tell you when the Irish systems are going to be back up. I know my colleagues are working very hard on that, but I don't know. And Jeffrey's sort of meme around complex adaptive systems. These are complex adaptive systems, and we can't apply linear change. And we're actually finding that as we try and start these systems up and running, there are so many interconnections and complexity that is challenging. But this is a new era, there's a new gauntlet being thrown down to healthcare systems of the world, and we really need to embrace the philosophy of defensive information warfare, so that we're collaborating together to increase our defenses, and hopefully we can do that faster than the bad guys can come up with new ideas to destroy it. So that's sort of my thoughts on you.
Yeah, thank you very much, Martin. And you made me think there of Leo, I think it was you have often referred to as digital and information as the glue and the grease of integrated care. And also, Jeffrey, I must say, your 9 themes that you went through in your talk are very similar to the 9 pillars of integrated care in our vision document that Leo edited and authored last year. So we have an awful lot in common. And I find myself also thinking about, I'm sure you've come across Daniel Kalman's latest book on noise, system noise, and talking about artificial intelligence. So I'd be very interested in Michelle and Carolyn's views about, with all this digitization and artificial intelligence, are we in danger of losing the human part, the human aspect of health and care? And if I ask Carolyn to respond first, please.
Sure, and thanks so much for having me on this excellent panel, and thank you to Jeffrey for a really compelling and great talk and great paper. You know, on the question of whether AI and new digital solutions are going to kind of erode the human in technology, there are a number of great books, and from Eric Topol had a book out recently on that topic as well. But I'm also affiliated with the AMS Healthcare Organization here in Ontario, whose entire mission is how we can ensure compassionate care delivery while using digital health systems, including AI and other more advanced technologies. And what it comes down to is understanding the nature of compassion and human connection and where technology fits in that. And sometimes creating the option of different technological ways of connecting is in and of itself a compassionate act and can create relationship building. And then also thinking a little bit differently about what the technology is doing, not necessarily just connecting us in a functional way, but creating an opportunity for kind of that relationship building. So, you know, AI systems that aren't necessarily, you know, informational or interactional in this way can still create opportunities for relationship building by creating new avenues to understand the person and the community that you're serving. And at the end of the day, it's about understanding, and it's about connection, and technology can support that. But we need to be mindful and purposeful in the application of those technologies, and think about that in the journey of healthcare delivery to individuals as well as to communities over time.
Thank you very much, Carolyn. And Michelle, have you any thoughts on that?
Absolutely. I think just to kind of pick up where Carolyn left off there is so much to be done on you know, how to make it more compassionate and how to work hand in hand with people and technology. But just to come back to something that Martin said, you know, a lot of the technology that is in healthcare is older technology because there are such wide implications to updating technology. So when we talk about AI and machine learning, while yes, absolutely is a massive role to play, the one thing that we have to not underestimate is the cost of the infrastructure underneath it and actually getting that up to date and up to scratch. Because you can have all the AI in the world, but if the information is in files down in the bowels of a hospital, how are you going to get that information? How are you going to access it? How are you going to make sense of it? Because it's all just in little paper files. So I think going forward, the one thing that we have to do, and to your first question as well, is how to get people to understand. It's that communication piece. And I think the HSC have been doing an amazing job of explaining to people what is happening, what's happening with their appointments, but also to get people to explain and to build that trust again in digital and in applications. And the big thing is that if you have a pot of money and you say, I want to upgrade a system, or I want to invest in a clinician to see more patients, it's very difficult to say, well, I'm going to choose a technology over the clinician. So I think it's building that understanding of Yes, we do need to invest in our clinicians, obviously, they have to see the patients, but also to support them and to actually allow them to do their job. That investing in technology needs to be a real part of our systems and our healthcare systems going forward. And when we get those kind of simple, basic things really, really done well, then we can look at how we can implement AI and machine learning, which will absolutely have massive, massive implications going forward. But just right now, and I suppose where all health systems are across the world, it's getting that information out to people that we do need to invest in kind of, you know, the basic systems and what we're doing, get that right, and then follow on from there.
Thanks, Michelle. Yes, the lovely to see you picking up on the communication piece, which really is the thread that goes through all of these things. It touches on Jeffrey's talk. It touches on what the different questions that we're grappling with today. Thank you very much. Just on the, I think it's really important, and we've really seen this in over the COVID-19 pandemic, is that digital has been absolutely fantastic for some, but not all. And digital exclusion has really emerged as an issue, particularly for marginalised groups. So how can we tackle that issue? And I'd like to ask that question of Donna and Leo, please. So Donna, if I could invite you for your comments on that first, please.
Thanks very much, Áine. I mean, I think it's been very interesting actually that, you know, we've been touching on your first question, which was around, you know, how in terms of the impact of COVID and this recent, the issue with HSE and cybersecurity attacks, you know, what's the impact going to be of that? And I think how we communicate with our end users, our citizens, us as citizens, in terms of the trust that we have in our health and care systems, that's really, really important. And obviously how we're, you know, how we do that effectively. And I think that is about being honest. Everybody, I think, is very much aware that in this new digital world, and it's not so new, but in a health and care environment, it's relatively new. And obviously with the impact of COVID, we've seen a huge increase, I suppose, in the delivery of health and care services using digital as a delivery means. Everybody is aware that this now has opened us up to different types of challenges like cybersecurity issues. And I think one of the things I wanted to touch on, going back to your earlier question, was the fact that prior to COVID, I'm not so sure that the issue in Ireland, it would have made a little bit of news and it would have been of interest to maybe in the digital world, we would have had a quick eye across the water to see how you were coping with it. But in this current climate, everybody is really interested in it. All countries and regions are looking to see, and they're there as a community, I think, to offer not only advice and support, but also really looking at how you're going to tackle this, because they're very aware that they are also, you know, at risk of a very similar event happening today, tomorrow, it doesn't matter. So I think that community issue is a really important one. And I think one of the impacts of COVID has been that it's brought health and care systems and countries and regions much more closer together. We're looking to see what you're doing and we're trying to support you in that and also learn the lessons for ourselves. But when we look then at the citizen and the impact of, you know, that trust issue around is there trust in the clinicians, our social care providers, whoever it is that we're interacting with through a digital means? Do we trust that digital interaction? I think that's where we really come into a very different ballgame. And certainly for us in Scotland, what we've experienced in the rapid rollout of technologies is that for those digitally literate citizens, it's been really welcomed. That digital delivery has been something that they've been asking for a long time. It fits better with their lifestyles. It fits better with their working lives. It's just it's the method that they would want to go for in their first choice. However, as you were saying, Áine, there's a whole raft of the kind of population that it doesn't fit for lots of reasons. It doesn't suit them. It's either because they don't actually have access to the internet in the first instance. They may not have the financial means to access it, so they don't have access. They don't have a device that they can access those services, and they don't have the skills to access those services. So I think that's brought to light a whole raft of issues that we've always known were there, but they haven't been as important. And what COVID has done is actually really rise those issues right to the surface. And it's meant that certainly regions are having to look at that. So we're seeing a lot of new digital inclusion policies coming out, looking at new ways of delivering digital skills, creating infrastructure to give equitable access to broadband. I think we're seeing, national initiatives where we're putting devices out to certain groups of the population and training to support them in acquiring those skills. So that was a bit of a broad-ranging response, but I think this has been a long time coming, and we're very, very pleased to see it as being treated as a priority.
Yes, thank you very much, Donna. And Leo, can I invite your thoughts, please?
Yeah, thanks, Áine. And I guess just extending Donna's point here, yes, it is unquestionable that we have a digital divide, and that this is recognised. And I think many of us are looking at ways that we can actually address that digital divide by our regional country approaches to broadband and mobile phone capability, for example, looking at ways that we can utilise our public estate better so that people that don't have access may be facilitated to have access to the digital world. But it does raise the question of why suddenly are we focusing on this digital divide, whereas prior to COVID and this rapid expanse in digital, we didn't care, seemingly, about people's difficulties in accessing in-person services. You know, I live in Wales. A lot of our services are in our, coming back to Jeffrey's point, centres of excellence that are miles away from many of us. And we might receive an appointment for 9 o'clock in the morning for something that is going to take us 2-3 hours to get to, even in our own cars, assuming that people have got the wherewithal to have the transport to get them to those 9 a.m. appointments. And yet, you know, how difficult would it have been for us to do appointments by postcode, you know, and schedule people that live a further distance away that is going to take them time to get to somewhere a later appointment, for example. So, you know, I think it's great that we are addressing it, but this is a broader issue, and it won't be a digital first. We will have blended approaches in the future, and we should be applying the principles of access to both in-person and digital, and then we will be providing better services for people.
Thank you very much, Leo. So we have a question from Albert Alonso for Jeffrey. Jeffrey says, thank you very much for an excellent talk. And he'd like to know your views on the use of IT advanced ways of analysing complexity in the context of healthcare, such as artificial intelligence.
Yeah, so this is a great question. Obviously, it's stretching the minds of many people across the world. So I think where artificial intelligence can come in is, and machine learning for that matter, is it can handle very big data sets and look for patterns in the data. I like to think about, you know, maybe this is the answer to the question. It's not really artificial intelligence, it's augmented intelligence. I like to think of AI not as something artificial. I mean, it's put in the information, and the algorithms are created by people. It's there to support complex decisions by complex decision makers. If we think about it that way, it's less sort of mysterious. It's another tool for us to make better clinical decisions, policy decisions, management decisions. And I think we sometimes think about artificial intelligence and machine learning in the wrong way. So maybe, I don't know if that's the answer to the question. You could write a book on the answer just to try and answer that question, but that's how I like to think about it.
Yeah, I really like it. It makes it like a less scary thing, a less kind of Terminator, it's going to take over the world type thing, and makes it actually this is something to support us. And can I just, Dan or Martin, if you or any of the rest of the panel, any thoughts on Albert's question?
Yeah, I think Martin might be. Oh no, he's there. He's moving. He's thinking.
Yeah, I'm thinking. Go ahead, Dan.
Yeah, I will admit that in Northern Ireland, in particular, we are a little bit behind the curve as it relates to application of AI in healthcare. I think Jeffrey's point is a good one. Try and demystify what AI is all about. I think about it as advanced analytics. It's the application of advanced data algorithms onto large data sets. The point was made by Michelle earlier, though, that getting your data into a place where you can start to apply AI to it is actually more of a challenge than working out what algorithms you need to write with all of the bright people who are capable of doing that. And so all of the basic things that we've been talking about in technology, in health and social care, frankly, for the last 15 years, digitize, and then make sure that all of your clinicians in all of your settings in the integrated care continuum are able to interact effectively with those data sets, to update them in a timely fashion, and then provide access to citizens to be able to populate and augment the clinical record. If you get that bit right, then the research community, lots of folks who are represented on this group today, can then go nuts on the data. The bit that also requires a little bit of thought, and certainly this is something we're thinking about over the next couple of years in Northern Ireland, is how you make it easier for the research and innovation community to be able to get access to those data sets. I like to use the phrase data as an enabler. And I think in many public health systems, we're probably struggling with that a little bit as we apply information governance frameworks that are by their very design about management of risk. And we are getting increasingly used to applying those, and more people are becoming familiar with data protection impact assessments and our relationship with the Information Commissioner's Office and all of that good stuff, which is all, you know, exceedingly useful, but actually can be quite a big hurdle to the research and innovation community being able to get access to data. So here in Northern Ireland, we're in the process of developing a new information strategy, which will likely recommend the creation of the Health and Social Care Information Institute that thinks about secondary uses of information and the legislation and regulations around that. It thinks about our information governance frameworks and how we apply them, and then how we build our human governance around those processes, and then how we start to do some of the things that we've done during COVID to adopt cloud technologies to provide ubiquitous advanced analytical capability to all data scientists and analysts around the community, to just unblock some of those barriers to being able to get access to that data. The AI bit will, if I'm being honest, Áine, that will have to come a bit later, because all of those challenges I've outlined are going to take us a wee while to address.
And maybe just to build, you know, Dan, that there's a massive opportunity for AI, and what we need is the exemplars. And those exemplars will then be copied, and we'll see, you know, very rapid diffusion. Obviously, we are data rich and information poor, and we're awash with data, but it's very distributed. And, you know, there are a few health systems that have, you know, comprehensive data lakes, but there are so many opportunities, particularly radiology. You know, radiologist, you know, has to read an image a second. You know, based on the volume of work that they're being asked to do, and a machine is far more suited to actually doing that than a human. And if you combine the error rates of a human radiologist and a machine learning program or an AI program, you get actually a much lower rate of error. So I think it's down to the exemplars. We had a really good example. You know, GDPR obviously is playing a very important role, where company we're working with were using AI for diabetic retinal scanning, and it took a 5-day process and turned it into a 5-second process. So not just a 10x, but a 100x change But unfortunately, because the consents weren't appropriately requested from the patients before the study, it actually had to be, you know, written off, and we've had to start again. But that's the kind of, you know, performance and you know, benefits, and we're hoping to start with St. James's Hospital using an Israeli company called Zebra, taking their archived CT scans and scanning for actually compressed fractures of the spine. And the earlier that they're caught, actually, you know, the quicker you can intervene, and the much lower the long-term pain. So I think what the world is waiting for is the real exemplars. We have sort of, you know, some lighthouses around the world where AI is being used, but it will happen very, very quickly. And I think radiology is the area where actually we need it most, and there's, you know, very high and visible benefit.
Thank you very much, Martin. And you're both actually throughout this panel discussion, I can't help but thinking about the really nice example of the creation of adaptive space that you have described, about the, you know, the identification of innovation, the testing of that innovation, and then the operationalizing of that innovation. So very nice bit of complexity science right there. Next question is from Deborah O'Neill in Trinity. And she's interested, she says that despite all the evidence-based research, why do you think culture is still discussed but not operationalized in healthcare? And I'll throw that one open to the whole panel.
I might jump in on that.
Please, Carolyn.
A little bit, because Leo and I were having a bit of a sidebar conversation about some of these kind of nebulous concepts. And it kind of comes back to the conversation we were just having around, you know, AI systems. And what occurs to me, and in reading Jeffrey's paper and in the talk, is about the kinds of data that we're collecting and what it's actually picking up on, and whether that is, you know, meaningful and quality, and, you know, related to quality, and is going to drive us in the direction that we're trying to get to. And a lot of the data we're already picking up on are built on kind of concepts and evidence based in old ways of thinking and on particular populations, and that may have controlled for other populations we're actually trying to serve. So if we're pulling in that kind of evidence base, we're pulling in particular data systems that are built on kind of legacies of how we've thought about quality and indicators over time, we might miss the opportunity to go in newer directions that are more, you know, formative and transformative. So I think being really critical about the evidence that we have, and thoughtful about whether that's really achieving the aims of the model of care and the people we're trying to serve and communities we're trying to serve, both from the evidence-based end of things, but also the data we're using to inform our AI systems or to transform our systems formatively. So I guess a call to not just the formative approach to transformation that Jeffrey speaks about, but also a formative approach to how we think of data and our data systems.
Thank you. We've got a very interesting question in from Anne Hendry. And Anne wants the panel, please, to point to examples of community hubs and third sector support to address the digital divide. So if Leo, shall I start with you for that one?
Thanks, Áine. I was just replying to it in the portal, actually, saying that I myself am still a volunteer coordinator for our local coronavirus group serving our local community. And I actually helped a number of people locally to be able to use their smartphones and their largely smartphones and tablets to connect to friends and family during the first lockdown. And that was done via leafleting, door-to-door leafleting that we did as a group of coordinators, and also Facebook, where their friends and family would see that we were a group that are there to help. So it wasn't through formalized third sector help. I think there were third sector things as well, but this was an example, coming back to Jeffrey's point in his talk, about how the social media can be used as an enabler to be addressing some of these sort of Are they really gaps? Their needs that have been identified because of a particular situation, rather than being necessarily considered a gap beforehand. And I think it's great how, you know, there's lots of good examples of very informal communities stepping into meeting people's needs.
Yeah, thanks, Leo. And Donna, I see in the chat that you made reference to Scotland's digital inclusion programme, Connecting Scotland. Do you want to mention that?
Yeah, Áine, that's so the Scottish Government has been working very closely with the Scottish Council for voluntary organisations to develop and now deliver a programme called Connecting Scotland. So that's really about trying to mobilise our communities in supporting this agenda, but also enabling citizens and families and friends, as Leo says, to actually, you know, deliver a lot of that support and advice on digital inclusion. And we are also targeting specifically our care homes. We just certainly don't have time in this panel to get into care homes, but that certainly was one, I suppose, population, if we want to call it, that we really were very much socially isolated during this whole COVID pandemic. They weren't able to see relatives and friends. And that was one particular population that we wanted to really support, not only from a citizen perspective, but also the care home providers, and actually supporting them to deliver health and care in that environment in a safe way. So yeah, that's I suppose the example from Scotland.
Thanks. And Michelle, you had mentioned earlier some work that you had done through the Sláintecare Fund.
Absolutely, and the SMILE project in CareDoc is supporting patients at home to monitor their vital signs at home with pulse oximeters, blood pressure cuffs, and other devices. And then information is automatically fed back to a main system where it's monitored by telephone triage nurses. So they schedule calls with patients, but then if anything alerts out of the ordinary, they'll make contact with the patient as well. And the big thing during the pandemic is these patients have many chronic conditions, and were obviously cocooning and were isolated. So not only were you looking at the healthcare aspect of it, there was also that social aspect and the mental health side of things. And, you know, even just explaining to people what the pandemic meant, what it meant to them, how they could, you know, navigate through the different avenues of it, how they could get their shopping. And a lot of the participants just said, you know, they really miss their family being around, and they really look forward to the nurse calling them. So there's that whole, just that social piece that made such a massive difference. But on the digital exclusion side of things, I think it was really important that we actually supplied the technology for the patients. So rather than expecting them to have an iPad or have any sort of tablet to be able to work the software. Now, in a previous iteration of the project, they had actually supplied internet access for the patients as well, which I thought was fantastic. It was just due to I suppose, the length of time that we had around our project, we didn't have enough time to do that aspect of it. But I think it's you know, thinking about all those factors and seeing how you can make it better for patients and include patients and support them just to learn and not to be afraid of the technology as well.
Yes, yes.
We have people who brought it on holidays with them before the pandemic, and even brought it into hospital with them, and we're still monitoring even though they're in hospital. So they really bought into it, and we're really passionate about it.
That's excellent. And just before I hand back to Sloan, one of the key messages that I'm taking out of this morning's discussion is connectivity. Rich connectivity, so whether that is between people or using technology and digital innovation to support that connectivity, I think that's going to be my take home. So with great pleasure, my thanks to the panel, and I'll hand you back to Sloan.
Áine, thank you very much, and thank you for convening an excellent panel discussion. No mean feat, given the range of excellent panelists and Jeffrey's presentation. Thank you, everyone. I'm going to finish then with some dates for your diary. We've got the ongoing series of webinars in IFIC Ireland, both our main webinar series and also our patient empowerment webinars coming up. The next webinar actually is covering ICT developments in Northern Ireland. Dan's colleague Gary Loughran is going to be presenting on that, so we're looking forward to that very much. But if we move to the next slide, the top line is relevant. And this, I'm delighted to say that in Carolyn's hometown, the first North American conference on integrated care is going to run from the 4th to 7th of October. It's going to be virtual, so we won't be there in person to see that beautiful city. You got a hint of it there in Carolyn's background, but the dates are still open for abstracts. If you're working on those, please make sure you get them in by 31st of May. So that time has beaten us. That completes our IFIC Ireland plenary. I want to thank everyone involved, Fiona Line, Karen O'Connell, who got everything together, and our colleagues at Abbey Events who've been excellent in sorting us out. So you've got some contact details there for IFIC Ireland. Please do touch base with us if you have any new ideas, particularly for our webinar series. Thank you everyone for attending today on what was a wonderful plenary session. Thank you.